Cuban girl is early for the first time in her life. All right. We're going to go ahead and give you guys a couple minutes to jump on board. As you can see, I have a special guest. Wait, wrong way. That way. I have a special guest with me this evening who is bringing his expertise and knowledge on TMR and RPNI procedures. And if you think that's a mouthful, you're right. But there's a lot of good information we're going to be bringing you guys this evening. All right, guys, as you come on board, I see some folks popping on board. You know the routine. Let us know who you are, where you're from, and if you're a cool kid and you got a Cosi. Do you have have I sent you one yet, Dr. D'Addesi?
No, I'm not privileged enough to have one, but that's okay.
We call it.
If you send me one, I would love to have it. And I'll think about you every morning I drink.
We're going to have to send you one. It's called the Cool Kids Club here on the Cosi Talk Show. The ones who have the mug are, they're in the club. Hey, Debbie, glad you could join us this evening. That's my girl from St. Pete, Florida.
Oh,
all right. Yeah. So we get people from all over joining the show. Okay, guys, I see you. Can you guys give me a shout out in the comment section? Make sure my chat box is working. Mark, there you are. There's my man right there. Thank you, Mark. I'm glad you guys can hear me. I didn't use my microphone tonight. I didn't want to tempt the gremlins in my computer because it tends to not work sometimes. We got Lena. There's one of my clinicians right there. What's going on? We got Eric on board. Dr. D'Addesi, can you see the comments going up?
I do. I see them.
Good. Okay. So we are good to go, guys. All right, guys. I know we're starting a couple of minutes early, but we have a lot of really great information coming in. There's Jeff, man. You are killing it in inpatient rehab. Thank you so much for sending me your updates. We got William Mays in tongue-tied. In Richmond. Matthew, what's going on, man? Matthew, you were killing it in that video last week. Good. Dick Devers in West Virginia with his Miller Lite. There we go. Debbie's a cool kid. There's Johnny V. Oh, Johnny V, you're another cool kid, right? You got one of the mugs? We got mugs and we got beer glasses. So, we got,
Johnny V's a good paisan right there.
Yeah,
Johnny
that's right.
Bravo. That's
from Poughkeepsie, New York. He didn't put his full title in. Usually,
man, he's from New York.
Yeah. Oh, yeah. We got Kenny Jones and David Couch. Oh, my gosh. Good group popping up already, guys. We're going to give you a few more seconds, and we are going to get started. Again, we have a lot of great information. Bonnie, there we go. Oh, I am so glad you could make it. She just had her RPNI surgery.
Yeah, you were telling me a little bit about that.
Yeah. So, Bonnie, I am so glad that you were able to make it. How are you doing? How are you feeling? All right. You're going to give us firsthand knowledge. Debbie's like, I'm going to get a Cosi Talks class. All right. All right, guys. Oh, and Rita from my YouTube channel. Guys, just as a side note, I am broadcasting also to my YouTube channel. So for those of you who don't particularly care for Facebook and have a tough time managing there, send folks to the YouTube channel and they can find me there as well. Hey, Vicky, I'm glad you could join us this evening. All right, guys, we are going to go ahead and get started because we have a big show with lots of great information. My name is Cosi Belloso. For those of you joining us for the first time, welcome. And next to me is Dr. Leonard D'Addesi, orthopedic surgeon, and he's going to tell us a little bit about himself. So for those of you who are here for the first time, I am a physical therapist with about 18 plus years of experience, going on 19 sometime soon. I practice here in Tampa, Florida, and working with the limb loss community is my passion. So I'm going to let Dr. D'Addesi introduce himself.
Yes, I'm an orthopedic surgeon. I actually specialize in hand and upper extremity surgery, but I have a passion for nerve surgery and especially TMR. When I learned about that, I jumped right on the bandwagon because I thought this is fantastic. And it really does work. But I enjoy doing this procedure. I love nerve surgery. I love reconstructive surgery. I like moving things around to make people work and function better because that's really what it's about, right, guys? I mean, some of you, have had unfortunate accidents or whatever, but it's all about function, and I'm sure, Cosi is getting you guys back to being active, but we have great surgeries now that can help you guys too, so that's what I'm all about.
Yes, and if Dr. D'Addesi's face looks a little familiar, it's because this is not his first time in the hot seat on the Cosi Talk Show. He came in last year and talked to us about targeted muscle reinnervation. And some of you might be wondering, well, why am I doing this again today? Number one, it's always repetition is the mother of memory, guys. And there's always something new that we can learn. I was having this discussion with Dr. D'Addesi yesterday. It's just even reviewing the material, I'm learning more as a clinician. And I've had more clinicians joining the show. So this is a good time for them to learn. And also tonight we're going to be discussing RPNI, Regenerative Peripheral Nerve Interface. Did I get that right? So we're going to be talking about these two procedures that are very similar in their purpose, okay, but there's little differences here and there. All right, so Jeff says I had TMR on my BK. All right, good deal. All right, guys, and feel free to start posting the questions in the comment section, guys. You know I love to have an interactive show. So Bonnie says it's my first full day in rehab, lots to get used to, and I'm hoping the RPNI works.
Yeah.
Okay, guys. So we're going to give you just a quick history on surgical amputation. And the reason is it's going to give you a better understanding as to why TMR came about. Okay, so one of my, I'm big on medical history and I love military history and Spanish history. So not too long ago, I got to visit the Spanish Military Hospital in St. Augustine, Florida. It's the oldest city in the United States. And I go into the Spanish Military Hospital and lo and behold, what do they have is all the surgical instruments on how they used to do amputations back then. Right? And the tour guide was telling us that in the mid-1500s, guys, mid-1500s, these surgeons could perform an amputation in under a minute and a half, right? And as they described how this was done, it kind of dawned on me, it's very similar to our surgical techniques today. The surgeon will go through the skin, then through the soft tissue, the muscle, the tendons, the nerves, and then finally the bone. And then everything gets closed up with the skin flap, stitched up, and off you go. So surgical technique when it comes to amputation has not changed too much in the past 4 to 5 centuries. Our anesthesia has improved, and that's a very, very good thing, right? So Dr. D'Addesi, is this something that, when it comes to the history of amputation?
Yes, no, I totally agree with you. When you were saying that, I was actually thinking like, my gosh, a minute and a half. Like, how did they clamp off the vessel? There must have been blood everywhere. Like you can't do it. You can't do an amputation in a minute and a half. That's impossible. Like I'm just thinking about all the surgical problems that you get. You can chop somebody's leg off doing a guillotine amputation, but you got to clamp the vessel off. You got to make sure the soft tissues are fine. At the same time, they were doing a lot of amputations for problems that we can now fix.
Exactly. Yep.
Right.
Yep.
So back then, you got shot in the leg. There were no antibiotics. You were going to get an infection. You could even die from that. Now, so back then, they would just chop your leg off and close the wound up. You had a higher survival rate.
Yep.
Now we fix it.
Yeah, it's a more polished, that's for sure. And I asked that same question, and they showed me the tourniquet. It's actually very similar to the modern tourniquet that we have in the OR. Right. And they said, well, they had a hot poker waiting to cauterize anything that was bleeding, and it was incredible. It was incredible, and they had to do it so quickly, guys, because they didn't have good anesthetics, if any anesthetic at all, especially in the Civil War, where it was just one after the other after the other.
I'm sure they had a piece of wood that they bit on. That was the anesthetic. Yeah.
And then, as you can imagine, many people were lost because of infections from the amputation itself, everything going on there. Yeah. So thankfully, our sterile technique has improved. But unfortunately, we still have certain complications from the surgical techniques that are still being used. And we're going to get back to that. We're going to circle back to this. So just keep the history in the back of your head, guys. Okay. Now I'm going to kind of switch gears just a little bit. So unfortunately, I don't talk enough about upper extremity amputation here on this show. I don't show my upper extremity amputees enough love. So tonight we're going to do a little bit on their history, and I'm going to show you how it relates to the TMR for you guys. All right. So guys, when it comes to the upper extremity amputee, the arm amputee, there's 3 basic options for a prosthesis. Cosmetic, which is exactly just that. It's just a cosmetic arm. There's no function. A body-powered prosthesis, okay, and that looks more like a traditional socket, and the person will move their shoulder to activate what's going on, right? And the myoelectric, okay? Some of you may have heard the term myoelectric prosthesis. This is where science fiction meets reality, and it is so cool, okay? With myoelectric, you might also hear it as the mind-controlled prosthesis, okay? So basically the way that works is there's little electrodes within the socket, and they pick up the EMG, the electrical signals from your muscles, and that controls the prosthesis. It's more natural. It's more in tune to the way your brain will work, okay? But in order for myoelectric prosthesis to be really, really effective, an upper extremity amputee should have the targeted muscle regeneration surgery, the TMR surgery. How long has that surgery been around, doctor?
It actually started about 16 or 18 years ago, and it was started because they were thinking about how to, get prosthetics, the myoelectric prosthetics, to work better, and they thought about maybe moving some nerves around to really target specific muscles so that they can achieve specific movements with the myoelectric prosthesis. It didn't develop into a treatment for phantom pain and neuromas until they realized, hey, this works for phantom pain and neuromas, right? So that took a little while, but then at the same time, it took a little while for it to get ingrained in everyone's mind that, hey, this really worked for phantom pain. And now it's been an exponential increase in the amount of procedures that are done, at least over the last I've been doing it now for 2 to 3 years. Mm-hmm. And I got into it when it was just starting to take off. And now it's like, oh my gosh, everybody knows about it.
Yeah. And I'm hearing more and more from my own viewers about them asking their surgeons about this procedure or having it done for revisions. So guys, let's just give you a quick demonstration. And I'm pulling up my reluctant model, Bob, here.
Oh, there's Bob.
There's Bob. Bob had to make an appearance. All right, guys. So I always like to use shoulder disarticulation, and his clavicle is also dislocated. Shoulder disarticulation as an example of how TMR can work. So in a shoulder disarticulation, all of this is gone, right? And what's basically left is a big pectoralis muscle. It's that nice, big, juicy muscle on the chest for both men and women. Now, the good news is the pectoralis major muscle, it's still there, it's still working, but the bad news is it can't do anything. It's not attached to anything anymore. So it's kind of just useless sitting there. Okay. So surgeons like Dr. D'Addesi said, let's put this thing to use, right? So right. In a very fancy electrical rewiring of the muscle. Okay. So as you guys know, every muscle is controlled by a nerve or more than one nerve. So what the surgeon will do is they will cut the nerve to the pectoralis muscle. I think it's the lateral and medial pectoral nerve.
Right.
Right? Okay, got that right. They'll cut the nerve to that muscle. So now that muscle is a free agent, right? And then they take the remainder of the nerves that are left here, that are just kind of out in the wind here, and plug them into different sections in the pectoralis major muscle. And what's really cool is surgeons will put this in a way that's intuitive. So what do I mean by that? The nerves that control shoulder flexion, right? The nerves that control elbow flexion, they're going to go up top and on the middle. The nerves that control extension, moving your arm and shoulders back, it's going to go more towards the bottom. So it's just more naturally intuitive as to where the placement of these nerves are. Yeah, that's pretty cool.
Yeah. The nice thing is you can more accurately use a prosthetic if you can take those nerves, which are mainly the median, the radial, and the ulnar nerves, nerves at the very end of the brachial plexus, mm-hmm. and you plug them into those different parts of the pectoralis muscle. And now when you want to have certain movements like elbow flexion or, opening of the hand, elbow flexion would be, a different nerve. But let's say you want to open the hand in your prosthetic, you would use the radial nerve. Wherever you plug the radial nerve, you'll put the electrode on that muscle. Wherever you want to make a fist or close the hand, you put the electrode on that muscle. That's the median nerve. You'll plug the median nerve into that muscle. So that's why it's called targeted muscle reinnervation.
And what's really cool, guys, and here's the big difference between body-powered prosthesis and something like a myoelectric with TMR. If you think about it, body-powered, right? The person is moving shoulder muscles to activate their elbow. So the brain is sitting there going, wait a second, these are supposed to be shoulder muscles. They're supposed to be moving the shoulder, not elbow and hand. But that's what the person with a body-powered prosthesis has to learn how to do.
Yeah.
The person who has TMR, they think about bending their elbow, and the elbow bends.
Correct.
So they're using their brain the way it was meant to be used to activate the prosthesis. Does that make sense, guys? Can I get a thumbs up, guys, if that made sense? And I'll tell you what, guys, I had to read this thing over and over and over again before it finally clicked in my head as to how this works. It's so intuitive. All right, let's Let's see, we got a few more people who popped on
It's,
here.
it's even more than thinking. Like, you actually perform the action, right? Like, you don't have an arm anymore, but if you want to open your hand, you think, okay, I'm going to open my hand, and you try to open up your hand, and then the myoelectric prosthesis will pick up the correct electrical activity, and then the hand will open.
Yep.
Right?
Yep. Absolutely. And it's much more intuitive. Now, guys, the recovery process, the person has to learn how to do this. So it's
Right.
a two-part procedure where the nerves have to basically spread and just kind of get rooted back into that muscle again to start working. But then also the person, usually with some sort of biofeedback, meaning they'll be looking at a screen at a hand and they will focus on trying to get that hand to open and
Right.
close, right? So there is some training involved. And interestingly enough, this is, Jeopardy, final Jeopardy question here for you nerds. It's easier for a person who's never used a prosthesis to learn how to use myoelectric. Isn't that interesting? Because the person who's been using the body powered, they have to unlearn those habits and learn some new ones. So I thought that was kind of interesting. So Bonnie, we're going to be answering that question. And her question is, does RPNI surgery take longer to heal from in comparison to TMR? Okay, and we're going to get to that in just a minute, guys, because we want to talk a little bit about both those procedures, right? So here we are talking about all the wonders of myoelectric technology for the upper extremity amputee, but many of you are probably going, well, we haven't really seen any of that technology trickle down to us lower extremity amputees yet. And you're right, guys, it does take a lag. Usually the fancy technology starts with the arm because it's a lot more fine motor movement that's involved in it, trickling down to the lower. So that's just a little ways off. But as Dr. D'Addesi, I keep pointing in the wrong direction. As Dr. D'Addesi pointed out, they started discovering that the byproduct of TMR surgery was that it did wonders for neuromas and phantom pain, right? So guys, another Cosi poll. How many of you, and I better see comments in the comments section because y'all send me emails about this. How many of you have phantom pain? Phantom pain that's triggered by a neuroma that you know because you have a neuroma sitting there. How many of you have been treated for a neuroma, or how many of you just have pain in your residual limb and you have not been able to identify it yet? Comment section, go. Okay.
There are some really, really good questions here.
Yeah. And guys, I promise you, if we do not get to your question after the show is over, I go back and I look at all the questions, and any questions that we might miss, I will go back and make sure we answer them.
So I'll just, would you mind as you're looking through that, if I just give like just a basic, discussion between the difference, about the difference between TMR and RPNI?
Yes. Can you describe a little bit about how TMR works in the lower extremity?
Yes. Well, it's the same way in the upper extremity, but the bottom line is this. When you do targeted muscle reinnervation, you're taking a nerve that was severed, okay, and you're plugging it in somewhere so that it has something to do. When you cut a nerve, it's like a down wire. It's sparking, there's electricity there, it has nowhere to go. Like, electricity wants to go somewhere. Otherwise, it's unhappy. The way your body deals with that is it forms a scar ball around the end of the nerve to try and protect it. And a lot of times that works. The patient doesn't have any symptoms, but sometimes it doesn't. And patients have symptoms. They get what's called a neuroma, and it can hurt. The other problem with that is phantom pain. People just feel this excruciating pain in the end of their limb. You can have phantom sensations. That's not the same thing as phantom pain. So phantom sensations are, you feel your foot, but it doesn't hurt. Phantom pain is, I feel my foot and it is a crushing, stabbing, burning, ungodly pain that I can't sleep.
Yep.
So a couple things that you need to know baseline. One, generally you like to get to the problem. If someone has an amputation, you like to get to the TMR within about 4 to 6 weeks. That's ideal. Studies have shown that you can still do it years later, but the longer it goes, the less likely it will work, right? So I did TMR on a guy who was 16 years out from an AK. It didn't work that well because they have cortical reorganization in the brain, And when the brain reorganizes, who we don't know yet whether it's going to reorganize back to where it was before or to something else. Okay? So I saw somebody wrote a comment, they had TMR, but it didn't work. When was your TMR? How was it done? How far out were you? Right? The chances of it working in a fresh amputation are very high. It is not going to work at every single time for whatever reason. We don't know why yet, but very high rate of working, very good results. 80-90% chance of no phantom pain, no neuromas after TMR in a fresh amputation. Okay, and still good 80% chance of it working in a person who's had an amputation within a couple years. So TMR, you take a severed nerve, you find a nerve that's working, that's already plugged into a muscle. It has to be a motor nerve, not a sensory nerve. It has to be a motor nerve. You cut that motor nerve to the muscle, and then you plug that nerve into that muscle, into the nerve that's going to that muscle. Now that nerve has somewhere to go. And you're like, well, wait a second. You're cutting one nerve to fix another. What happens to the other nerve? Well, the nerves that give you the problem are usually mixed nerves. They have motor and sensory axons in there. The sensory ones are the ones that give you the problem because they bring information back to the brain. The motor nerves don't give you a problem. If you cut a motor nerve and it develops a neuroma, you'll never know it because it's not bringing impulses back to the brain. Impulses are only going from the brain to that neuroma. Okay? So the sensory nerve or the mixed motor sensory nerve that you just cut in the amputation, you got to plug that in somewhere. And you always plug it into, and only plug it into, a motor nerve. So you cut that nerve close to the muscle, right? Here's the muscle. Here's the nerve that plugs into the muscle. You cut the nerve close to the muscle, and then you plug the mixed motor sensory nerve into that muscle close to the nerve so it can sprout and immediately grow into that muscle. It now has somewhere to go, and the circuit is closed. If anyone's like an electricity buff or an electrician, the circuit's closed.
It's a closed circuit. That's all you need. Exactly.
Right.
Exactly.
With RPNI, you're doing something sort of similar, but radically different. You're still plugging the nerve into a muscle, except you're not plugging it into a nerve. You're actually cutting part of the muscle and elevating it and wrapping that nerve with the muscle. And you say, well, how does that work? Well, number one, you need to denervate the muscle. That's what you're doing with TMR when you're plugging it into a motor nerve. You're actually cutting the nerve supply to that muscle. It's no longer innervated. It has no more impulses going to it. So when you plug in a nerve to it, you're now giving it impulses. You're now giving it something to grow into it. With RPNI, you still need to denervate that muscle. So some people cut it completely off. It's now not only denervated, but it no longer has a blood supply, so it's a dead piece of muscle. Some people just elevate it so it's still attached somewhere, giving it some blood supply, so it's not dead muscle. But you want to cut the nerve supply to it because now the motor end plates are exposed and they are available for a nerve to grow into them. Again, closing the circuit. So with RPNI, you can still close the circuit because instead of plugging the nerve into a nerve, you're plugging it into the muscle, which still has motor end plates in it, and the nerve has something to grow into. Does that make sense?
Capiche? Yes, Andrew. Andrew is my OTs. She says the procedure sounds like grafting plants. And yeah, I'm just thinking my dad is grafting plants in my backyard all the time, and it has a very similar appearance.
That's right.
And guys, it's basically my kids hear me say this all the time. Idle hands make devil's work, right? So in the old procedure of the amputation where that nerve was pulled, cut, and then tucked back into soft tissue, it didn't have a job to do. So it's going to start causing trouble, right? So, Doug, that's a good question. He says, yes or no, phantom pain mostly consists of the pain you experienced before amputation, stabbing, pinching, twisting. So a lot of the theory originally behind phantom pain was yes, especially if the person had a traumatic accident. If they had a curry, then that's the last memory that their brain had. So it would translate into possible crush feeling during phantom pain. But Doug, I've had people that didn't have any pain. They either had a non-healing wound that was not necessarily painful. Some of these venous wounds from diabetes, they're not painful. They're just terrible looking. They had the amputation and they still had phantom pain, that it wasn't related. So it's interesting. In the 18 years, I've tried to figure out a rhyme or reason to who it presents in, how it presents, how it's aggravated. I have yet to find a pattern myself. So,
well, it's interesting that you say that, because have you ever seen any diabetics who've had amputations because of their diabetes? Maybe they even had peripheral neuropathy. Do you see them with phantom pain too?
I do.
Right.
And that makes no sense, because technically if they had that peripheral neuropathy, and this is a Cosi theory, guys, this is just me pulling a guess out of my ear, is if where the nerve gets cut for amputation, if the neuropathy hasn't reached that point.
No, I don't think it's that.
No.
Wait, let me rephrase that. I don't know if it's that. It may be that. I don't know. I've never heard that. But the point I'm trying to make is people get phantom pain regardless. It's when you touch that nerve, you're causing a problem. Yeah. So I'm giving a lecture on Friday, actually, to the hospital, the Department of Rehab, and I went to go visit with a vascular surgeon. And the vascular surgeons, they're the toughest, because they do the amputation, and a patient that has, vessel disease, ulcers, no blood supply, dead foot, whatever. They do an amputation, the wound heals, they discharge the patient. They're done. So when you talk about this, they're like, I never see phantom pain. Well, that's because you don't see your patient back. Okay? You're not seeing your patient back, and you're not asking them. All you're looking at is the wound to make sure there's blood supply there.
Yeah.
So they're the hardest ones. When I have a conversation with them, I'm like, just send the patient to me. Just send them to me. Let me evaluate them, So I'm going to give a lecture this Friday, and there are going to be some vascular surgeons there, and this is exactly what I'm going to discuss.
Well, it's better than having ornery PTs in your audience, I'll tell you what. We've got.
I'll take PTs over vascular surgeons any day of the week. Right? They get it. They're more mechanically inclined, so I can have a more intelligent conversation with them. Vascular surgeons are brilliant people, but they don't understand the mechanical stuff, right?
Yeah, it's a different animal for them, definitely. Yeah. So Van Gregory asks, nerves continue to grow and regrow. Yes. They form, to me, it amazes me how the nervous system in the body and the human body can heal itself. And I've mentioned this on the show several times, guys, just even things like traumatic brain injury and stroke, how the brain can just rewire itself and learn new things, and new neural pathways. It's incredible. Yeah. Yes, usually is it typically about 2 years after injury that a nerve has to kind of spread new rootlets?
That is probably the most important question you just asked. Mm-hmm. Because this is the key to nerve injury. The key to nerve injury is how long the motor end plate and the sensory organs live after a nerve gets cut. Okay? Mm-hmm. Sensory organs, right? The end goal, the very last thing that the nerve is going to reach, the sensory endings and the little Golgi apparati and other things in your skin, for sensation, the nerves can regenerate over even up to 5 years.
Wow.
Motor is vastly different. The motor end plates in a muscle live for 18 months. You have to get to the motor end plate before 18 months. Now, a nerve regenerates in a millimeter per day or an inch per month. Mm-hmm. Mm-hmm. The closer you are to the motor end plate, the faster you're going to reinnervate that muscle. If you're really far away, the chances are it's not going to make it. So if you're more than 18 inches away from a motor end plate that you want to reinnervate and you have a nerve injury, you have to fix that nerve right away, as soon as it's injured. If you wait any time, you're going to get a bad result.
That explains drop foot right there.
Yeah.
And that one's so difficult to get back because if you think of the length of somebody's tibia, it's usually 18
Yeah,
inches.
and especially if it's coming from their spine, right? I saw a lady today in the office that has, a drop foot from a spinal stenosis, and I'm like, this is never coming back. I know she's probably never going to get this back.
Wow. So we've got, all right, let's see, a couple comments that came through. And guys, again, I know we're going a million miles a minute here with all of this, but I will get to the questions if I missed it. So Debbie says, car accident and my phantom pain is of my crushed leg. Yep. And I had, oh my gosh, one patient, she lost it in a motorcycle, and a young woman. And as she was being transported, her foot was still attached and she felt the foot.
Yeah.
And how her phantom pain, like she was describing it to me, and I'm just like, oh dear heavens, that's a, whoo.
It's amazing what happens to people. It's such a shame.
Mm-hmm. And it's incredible when they come back, how they come back. So Jim says, my amputation was caused by a blood clot resulting in compartment syndrome, which is incredibly painful.
Yes.
Warnings prior, and I'm not diabetic. Let's see. All right, guys. So a lot of people obviously coming out with their stories of phantom pain. And again, guys, it is not a 100% guarantee. Okay. So Dr. D'Addesi, this leads to this question. Who would you consider to be a good candidate for TMR, RPNI, who comes into your office? How do you?
Yeah. Well, let me just answer one more question somebody had. Somebody wanted to compare between RPNI and TMR.
Yes.
I would tell you that I think they both work. They can both work very, very well. When people are like, well, I had RPNI, I'm like, great. And people are like, well, I had TMR, great. I often do a mixture of TMR and RPNI, right? So there are specific nerves that I know I can plug into a muscle, and I feel really comfortable doing that. And then there are some sensory nerves that I'm like, I can't plug this anywhere. Like I don't have anywhere to plug this. I take a piece of muscle, wrap it. I'll even sometimes bury it. The nice thing about RPNI actually is they're doing studies now where they're doing it and leaving it more superficial, like right under the skin, because the electrode will get much more amplitude from that.
Yes.
Right? So it actually works even better. You get higher signal amplitudes.
And no crossovers from any of the other.
Correct. It's very specific.
Very nice. Oh, here's an interesting question.
I think they both work to answer the question.
This one, Larry says, why not take the severed nerve and loop it back into itself? Would that work?
People have tried everything. Okay? They've tried everything. I don't think looping it back into itself would work. What does work sometimes is taking a nerve graft, connecting the nerve to that, but you take a long enough graft and just let it grow into the graft, and it kind of burns out after a little while. Like it can only grow so far, right? And then after 6, 7, 8 centimeters, it burns out, and that's it.
Got it. All right, we got a lot of great comments. Thomas says, like your Rolling Stones emoji there, Thomas. He says, I have a fused left ankle with drop foot and right RBK on the right. Tomorrow I have revision surgery for an infected tibia. So Thomas,
oh, boy.
If there's any questions that we can help you with. But that's also, guys, this is a great opportunity to say, for those of you who are facing a revision, for those of you who aren't, there's been a few people on the show that you had time to make a decision about your amputation. It wasn't a traumatic amputation where it was done right at the moment. You have the ability to bring these questions to your surgeon and ask them if they are familiar with TMR, RPNI. If not, do they know of any of their colleagues that are? Okay. And the same way I bring to you guys all the different options that you have for prosthetic feet, prosthetic knees, liners, socket design, suspension systems, and many of you are taking this back to your prosthetist just to ask them what your options are. You can do the same with these surgical procedures. It's not to say that you're a candidate, okay, but it certainly warrants a conversation. If you're facing a revision, right, it warrants asking the surgeon, what are their thoughts on these procedures? Yeah. Is there anything you want to add to that, Dr. D'Addesi, of how they can approach their healthcare practitioner?
Yeah, I mean, first of all, they need to ask questions. I mean, doctors are really busy. Sometimes I'll be in the room and patients are asking me questions, and I'm like, I got like 3 people waiting for me, and I'm thinking, I wish this person didn't have questions, but at the same time, I put myself in their shoes, and I'm like, all right, I got to answer their questions. It's not fair to them, right? Just apologize, say, I know you're busy, kind of meet them where they're at, right? You want to kind of meet, and the surgeon should be doing the same thing. They got to meet you where you're at, right? But it doesn't always work that way, let's be honest. Meet them where they're at. I know you're busy, doc, but I really don't understand and I feel uncomfortable unless you answer my questions. They have to sit down and talk to you, like they just have to do it. It's their job, right? But just be kind and courteous and ask your questions. You got to get them answered.
Yep. And guys, it's not to say, so but aside from TMR and RPNI, I know I have, for example, a local physical medicine and rehabilitation doctor, and she is a magician when it comes to injecting neuromas. I don't know how she does it, but the patients I've sent to her, they're very successful with the injections. That's not usually the case though. So, but this is just another thing I want to offer out there. And then
is that just temporary though?
No, I think it's a mixture of lidocaine and it's a very simple cocktail. It's nothing fancy. I don't know if it's her technique that she knows just how to inject it. But two of my
injecting right into the neuroma?
I know that I sent my patients to her because I had heard about her and I said, just go find it. And they came back to me a week later and they've only had to go back like once a year.
Never heard that before.
It's only one thing, but I have heard of other PM&R docs attempting to do injections for neuromas. Sometimes they work, guys. Sometimes they don't. I know sometimes they'll try to resect the neuroma, but oftentimes if you take a neuroma out and you don't plug that new nerve ending in, the chances of it reforming that neuroma again are pretty high.
Yeah.
So Patty asks, I had TMR in February at the time. The doctor said if this doesn't work, we can try something else. I assume that RPNI, will it still help to do RPNI? And she's 2 years out. She was the one who mentioned that the TMR didn't work for her phantom pain.
She's 2 years out?
She's 2 years out.
Did she have TMR like right after her amputation or at the time of her amputation?
Patty, can you put that in the comments section, please? Okay. And then as far as outcomes are concerned, you said you like to use both procedures and just depending upon what you're seeing in the surgical field will determine which technique that you like to use. Is there any difference in recovery time?
Not really. I mean, the nerve sprouts, it takes about 6 weeks to 8 weeks for the nerve to grow into the muscle. Especially with with RPNI, the muscle's right there. It is literally wrapped right around the end. Mm-hmm. So I would give it a good 6 to 8 weeks, and you're either going to see, a new neuroma form, or, you're going to have relief. The only reason a new neuroma would form in an RPNI is if you don't take a big enough piece of muscle, because you don't have enough available motor end plates for the nerve to grow into. Does that make sense?
Yep, sure does.
With TMR, if you plug the nerve into a motor branch that's very, very close to the muscle. I mean, they literally say, cut it within a centimeter of the muscle. Mm-hmm. Then it should grow right into that muscle. It should take very little time. And some people have seen activity in the muscle by 6 weeks.
Okay. So Patty says it was not during her initial amputation. It was done 2 years. So she's 2 years post, and she just recently had the TMR procedure.
Okay. So again, the longer you wait, the less chance it works, but there's still really, really good results. If they did TMR, I'm surprised it didn't work in 2 years, but they can try RPNI.
And just to see if they get the results there. All right, folks, we have had amazing questions here this evening, and we're going to go ahead and wrap it up. Like I said, if I did not get to your question, guys, you know how to email me either on Facebook, on my website. I will be going back through all these comments to pick up any questions that we have left. I do want to say a special thank you to Dr. D'Addesi. Thank you so much. I know you are so busy.
Yeah.
We really appreciate you coming on the show and sharing your expertise with us this
It was
evening.
my pleasure. I really enjoyed talking about this, and feel free, Cosi, if you have a burning question, one of your patients, to email me. I'm happy to get back to you. But I appreciate you guys listening. I know some of you are going through some difficult things, and many blessings to you. I really hope that you get some relief and good things happen for you. But Cosi won't steer you wrong. She's a really smart physical therapist in person, so she'll help you out.
Thank you, guys. And I'll be posting Dr. D'Addesi's website information on the top of this video post. If you want to show him some love, visit his website, check out his practice.
Yep.
In the meantime, guys, as always, thank you for letting us be a part of your lives this evening. We will see you next week. Same bat time, same bat channel. God bless, guys.
Bye all.